And the case that I quoted, I wanted to highlight there is a lack of specificity in management of these valvular diseases. And we actually put a very experienced cardiovascular anesthetist with obstetrical anesthetist. Both are very experienced to manage that case and a number of other cases. So it wasn't just sort of someone walk through the door, put on an echo, and try and let's see what happens. It has to be a very conscientious decision and due consideration given.
I didn't quite hear. Did you say, were you asking about echoes in individual patients? Antenatal. So I think echoes, I think, are almost a standard part of any anaesthetic management these days. 10 years ago, asking for an echo seemed to be a big deal. And in my other part of my practice, I do a lot of vascular work. And I think it would be unusual for me to anaesthetize a vascular patient without an echo these days. It's almost like doing a full blood count. It's a basic investigation. But I also think that echoes, they're not dynamic and they're not predictive. I think that once, a patient who has cardiac disease, a pregnant patient, I think you should definitely have an echo as a starting point. And then, I'm not contradicting what you say, but I think you need to be prepared to echo in response to changes. And I think, firstly, you need to look at how that woman is during pregnancy. And if there's any change or deterioration, I think an echo should be your first point of investigation to try and assess and decide what you do next. So I think that for me, the big thing is that all the recommendations we have and all the data is all very generalized, but management really needs to be individualized for that, individualized and responsive. So she may end up having 2 or 3 echoes, or she may only have 1 echo, but I think individualized and responsive.
Thank you very much. Thank you, sir. Thank you, madam. Now we'll go to the physio control lecture. Mechanical CPR, the benefits of LOCUS 3 for patients and the caregivers.
My name is Michel Vaillant from Physio Control, which is a Stryker medical company, and today really talking about benefits and advantage, especially for the patient, but also for the caregivers when using mechanical chest compression, and most specifically the LOCUS mechanical CPR. There are a few things that are already known, and I will not spend too much time on that, with regards to improving resuscitation. First one, and one of the most significant one that was specified in the Guidelines 2000 from the American Heart Association, is that minimizing CPR interruption will increase survival. So as long or the least interruption in cardiopulmonary resuscitation there is, ideally no longer than 10 seconds, you can really see an increase in survival. Also, increasing the number of individuals that are trained in CPR and in the use of an automated external defibrillator will also increase survival in the community. One thing that is known as well is that for every minute that there is delay from sudden cardiac arrest until you have CPR started and defibrillation, you'll lose between 10 and 12% chances of survival. The use of application as well to locate AEDs and rescuer to link them with victims also show some promises, and mechanical CPR in certain circumstances can improve survival also. But naturally, what about LOCUS and mechanical CPR? So let's look at a few advantages, the improvements that have been made over the years, and the connectivity about that. So Lucas mechanical CPR has been commercialized over the last 12 years around the world. More than 16,000 devices have been deployed and remains the market leader. We also have more than 200 publications, including the largest clinical study, which is the LINK trial, that has been conducted over a 5-year period in 6 or 7 major centers around the world, and that have proven that Lucas CPR is as good as high-quality CPR, high-quality manual CPR. And what does high-quality manual CPR mean is that all the crews, the people that were involved in the study, were trained twice per year for 1 day in cardiopulmonary resuscitation for manual CPR, which means that if we look at most hospitals around the world, if people get trained or retrained in CPR every 2 or 3 years, that's good. So in that study, they were trained twice per year, and that's against what we compared the Lucas mechanical CPR. Lucas is also appreciated and trusted, endorsed by many users as being easy to use and can be fitted onto a patient within 7 seconds, which means that we also, when we look at the guidelines, which says we should not have any interruptions of more than 10 seconds, well, you can reach that with Lucas. And once the device is applied onto the patient, it's very safe and it will conduct CPR according to the guideline. So at more than 100 compressions per minute, which is 102, at 5.3 centimeter depth, so between 5 and 6 centimeter, and it will do it according to either the ratio of 30 compressions to ventilation or continuous compression if the patient is intubated. Proven safe and efficient, both for the users and also for the patient, with over 99% good neurological outcome when Lucas is being used during CPR. And it provides as well consistent, high-quality CPR. Proven also to perform reliably, and more than 99% of documented studies with regards to its operational reliability. And it's also compatible for use in cath lab, which means that in many cath labs around the world, if cardiac arrest occurs during the PCI procedure, then they will install the Lucas and continue the procedure while Lucas is on giving mechanical CPR. Some of the advantages are the suction cup, which also does effective compression and decompression of the chest. And naturally, the device is also easy to install, quick, and easy to use. So this is how the device looks, the suction cup and the installation, with also for the cath lab a fully radio translucent backplate. Okay, so the backplate here that you see goes underneath the patient, and the device that you saw goes completely over the patient, ensuring constant quality mechanical CPR. Okay, and here you have some idea on how and the view you can have when Lucas is being used in a PCI, in a cath lab for PCI procedure, as to what you are able to see when the procedure is being given, depending on the solution you're using. The interface is very easy to use, as it allows you to do 30 compressions for 2 ventilation. It will automatically stop after 30 compression, allowing you to give 2 ventilations, or it will alert you to give ventilation every 10 seconds or every 10 compressions, when it's on continuous mode. The device also self-adjusts on the chest in order to make sure that there is the right application or the right force being given and that it prevents trauma as well on the patient. Naturally, any device, whether it's Lucas or any other mechanical CPR device, good training and during the in-service naturally and regular retraining of the team will ensure that it will be applied correctly, that it will work correctly, and that it will also be applied in a very short time frame in order to make sure that there's never any CPR interruption of more than 10 seconds. Some of the new advantages as well on the new Lucas 3 CPR machine is the fact that it now records data and it's able to transmit it as well. So data you will be getting out of the device will be what chest compression ratio did the patient get, okay, with the Lucas CPR device, what was the longest pause or stop into compression, and if there were any alarms or any issue that happened during the procedure. The Lucas will collect data with regards to the compression, the count and duration, any pauses that happen, user interaction on-off, readjust the device, any alert that would have happened, and also will inform you about battery status. Nevertheless, you also have AC or DC power that can be used with the device for continuous operation. And this data can be retrieved onto a computer and used for analysis. And you can get different reports that are being generated, which give you certain views, and these reports are very, very important, especially when you use debriefing following a cardiac arrest, because these reports will help you conduct your debriefing and increase the follow-up and the improvement into the use of the device.
1 minute,
What
please.
do customer value about the Lucas is, or the report that are being given, is the possibility to learn and improve from each code by reviewing when interruptions were made, why pauses were made, and what happened in altering that. And to confirm and also document the chest compression quality. So in review, and in light of the previous presentation, so the Lucas is easy to carry, can be used both into pre-hospital setting or hospital setting, and it's comfortable to use, not necessarily for the patient who gets it on the chest, but mostly for the user. And you also know that doing cardiopulmonary resuscitation, manual cardiopulmonary resuscitation, is quite exhausting. So naturally, Lucas will get this done with minimal interruption. It's cath lab compatible, easy to use, easy to clean, and also easy to carry. Thank you.
Thank you very much.
Thank you.
Any questions?
Thank you.
Thank you.
A few questions or a comment. Number one, you said that it is endorsed by users. I thought the first thing that companies come and say this machine or that device is endorsed by FDA or some regulatory bodies, but I thought that you said endorsed by users only.
No, it's endorsed by user. Naturally, the device, in order to be commercialized, has 510K and PMA approval from FDA. Okay. So the device is certified. We also have CE mark. It's also RCTA DO 160, so approved for flight. It has flight certification. But what I mean is that we have, with the 16,000 devices that have been deployed worldwide during the past 12 years, we have endorsement also from user who mainly tell us and others as well that it's easy to use, it gives performance, it helps them improve the management of the cardiac arrest, and it also helps them save more lives. So that's what I meant.
Number two, you mentioned that there is a 99% good neurological recovery. That's good to be true. That's
Sorry?
good to be true in terms of what we see actually. So if that's the case, then nobody should do manual CPR. It should be all your machine, basically.
Okay.
Because what we see in real practical life, that you should probably get about 10% of your patient will survive a code, and then most of these patients end up on machines, and the ICU, most of them will die.
Okay.
You have a very small percentage of people who will survive, with very few people who will benefit from your CPR to start with. 99%, I think it's way too many and too exaggerating.
Okay. When we talk about 99% good outcome is when there is patient survival and when Lucas has been used as the initial way of doing CPR, so meaning there is a cardiac arrest, Lucas is used immediately and the patient recovers. In 99%, the score for neurological outcome is either a 1 or a 2 in 99% of the cases. When Lucas has been used as the initial and there is survival. So naturally, it's true that you cannot save every patient. I agree with you on that matter. I'm not saying that Lucas is saving 99% of the patient, but those who are saved, and when Lucas was the first intention and the first technology to use as CPR, those who survive have good neurological outcome in 99% of the cases.
I'm very interested to implement this in our practice and see what's the outcome. I doubt it.
The documentation is there. I'm not just saying it. The documentation is there from the different reports that have been done, clinical trials, randomized trials with peer review. So
and one last comment. Again, this is nothing from your side, but what I have noticed and wherever I worked with this machine being available, that whoever was responsible for the patient used to hook patients on this machine and move on to deal with other patients. So the patient who is in a cardiac arrest situation, because of this machine is pumping on the chest, nobody's around the patient. So again, I see your point where cardiac arrest is an exhausting process by itself. It needs manpower or woman power to do CPR and so on. So the machine does this, but it also gives some people leeway of leaving the patient, go and do something else.
No,
and again,
it's
I'm
not
not saying
that.
Again, this is not with you.
No.
That's my observation with this machine being in use.
No. By having mechanical CPR and by having that uninterrupted CPR and good quality, it allows better management of the team during the cardiac arrest because you don't have someone standing over the patient, and it's much easier to move around, much more easier as well for the doctor who's in charge of the cardiac arrest to assign task to everyone and to ensure a better management. So it's not, it hasn't been made so that you can go and take a coffee while you're, while Lucas is on.
So, but the reality is different than what you are telling.
Yeah, thank you. No problem. I don't have any issue, as you can see.
Yeah. Good morning, everybody.
Good morning.
So, first of all, I'm Casualty Mubarak Hospital matron or ADN. I will give you just our feedback from using your machine on our casualty. The one we have is the old generation, I believe. We don't have the option on the modes that you can adjust every 30 minutes. The one we have will give continuous pressure. Our experiences during the crisis of bronchial asthma, the one we had on Thursday, that was 10 days back almost. We got a patient who's gone into cardiac arrest. They have been resuscitated using your machine, the old generation again, but it's the same concept. Honestly, what is practical that you can start and initiate the compression through the machine so fast. That one I agree. Within 7 seconds, honestly, you will have it in and you will start the compression through, which is more practical for us on the recess. But the feedback of getting the patient survive with the neurological recovery again, as Dr. Adel described, that was another issue. Because we had 3 patients who has been arrested, who has been resuscitated, and they reached the ICU, but all of them passed away. We did not get any patient back. They were alive, but neurologically they got into severe hypoxia, and we lost them all. It was a matter of time, even though for a while we thought that they have been resuscitated. So the outcome is still a question, but practical-wise, it's honestly so easy to be started the compression through, and that one is very practical on the research on casualty, but still the outcome, this is something I believe we need to look more closer on, and this is our experience, and recently, within only 2 weeks. Thank you.
Okay, thank you.
The outcome of any resuscitation depends on many things. Yes, it's not about only when you are doing the CPR. It's the primary disease of the patient, how you are giving it's not only the chest compression. The machine is giving the compressions, not giving the drugs, not giving the DC, not giving the nebulization, not doing the intubation fast or something else. Yani, this is what I think. Okay, thank you. We'll meet again at 1:30.
Thank you.
Okay, good afternoon, everybody. So now we're coming to our afternoon session. Just a few instructions before we start. So for the next 2 hours, we're going to be moving on to a general session. And for the audience, we're going to have the questions from the floor after the third talk. So if I may ask the presenters, after they're done with their talk, please join me on the table. And after the third talk, we will have the questions from the floor. So for the first lecture, or the first talk, going to be a consent and medical legal issues. And as you know, the Ministry of Health have issued a ministerial decision, which is Al-Qarar Al-Wazari, numbered 307/2015. For anyone who doesn't have that, I have it, to fully implement all the rules and regulations concerning obtaining a patient consent. Now, many patients can ask a lot of questions regarding a consent form. For example, what do we mean by an informed consent? Who is responsible in taking that decision? How much information we can give to the patient in order to obtain a consent? What is the validation of that consent? And last but not the least, what are the responsibilities of the medical team to ensure a consent is being taken appropriately? Now, all these issues will be discussed by our next speaker, and I have the pleasure to introduce to you. He's a graduate from RCSI, Dublin, Ireland. He's a consultant general surgeon at Mubarak Hospital. He's a fellow of the Royal College of Physicians in Edinburgh, Glasgow. He's a Kuwaiti Surgical Board certified. And in fact, he's the current program director for general surgery residency training program at KIMS. Please welcome with me Dr. Ali Ismail.
Thank you very much, Dr. Ibrahim, and thank you very much for inviting me for this conference. First, as Dr. Ibrahim said, that consent is very important documentation in the patient files. So that's why I will talk about it. So first, just an introduction that obtaining patient consent before provision of any medical care is the legal and ethical principle, and it's reflect the patient right. If you don't take a consent from a patient, well, this will put you in the legal issues. So nothing for the patient called the minor procedure. Whatever you want to do for the patient is a major for him. But we are physician, we divide into minor and major. But for him, all the procedure are major procedure. Now we have 3 types of consent. Non-verbal, that's when you want to take a blood pressure or you want to withdraw blood. And then we have another 2 types, the verbal or the informed consent and the written documented consent. Now, the consent to be valid has to be follow a few points. The person should be well informed. The person must be fully mental capacity, therefore capable of understanding what you are saying, have the ability to understand and give you the appropriate decision, understand the consequences of accepting or not accepting the treatment, and he has to be of a legal age. Therefore, he has to be 21 years old in a fully calendar year. And the consent has to be taken with the full free will, without any pressure on the patient. So why the consent is important? Because things can go wrong during any kind of a procedure. So consent is important for the safety and satisfaction for both hospital and the patient. Also, it's part of the ethical standards. It's a legal requirement from the physician. It's also important for the accreditation standards and also reduce the litigation. Therefore, it will save time and money. So consent is very important documentation of the patient file. So who's responsible for informed consent? Who's doing the procedure? So either he's a surgeon, physician, intervention radiology, or even anesthesia. So if we take the physician, he can take the consent by himself or by his representative. But this need a criteria. So he has to be experienced physician, qualified, knowledgeable. He knows the risk and benefit of the procedure, and he's able to answer any question that the patient may have in his mind. So the procedure that we need to take a consent is major or minor procedure which require intrusion or penetration of the body, either through puncture or incision of the skin, or through the body natural orifice. Other examples, procedure which require insertion of a device or a foreign material. In these cases, we need to take a consent, such as percutaneous aspiration and biopsy through the skin, cardiac and vascular catheterization and stenting, endoscopy that requires sedation. Also, any procedure that required anesthesia or sedation, such as general anesthesia, local anesthesia, nerve block, also we need a consent. What about a non-surgical medical procedure? Yes, like chemotherapy, because chemotherapy may lead to change in the body structure. So that's why we need to take a consent as well. Other example, intervention medical procedure, radiotherapy, electroconvulsion, intravenous contrast injection, and also blood component therapy, such as blood transfusion. So in general rules, so any procedure that you give a detailed explanation to the patient, or if you are in doubt,